10 years ago at MSF, it was a revolutionary success when a little girl with type 1 diabetes in the Central African Republic was able to come to a health center twice a day for insulin injections. Within a decade, in places where access to care is limited, we have gone from twice daily injections in a medical facility for people living with diabetes to another huge innovation: self-management of diabetes at home. Today, the number of adults living with diabetes worldwide has exceeded 800 million, up from 500 million in 2021. This explosion is mainly occurring in low and middle-income countries where MSF teams are working, such as Bangladesh, South Sudan, Yemen, and Syria. Globally, diabetes is one of the top 10 causes of death. About 10% of people living with diabetes have type 1 diabetes, which means they don't produce enough insulin, the hormone essential for regulating blood sugar levels. Without an insulin replacement, they will die in a very short period of time. The majority, about 90%, have type 2 diabetes, which progresses more slowly, but still causes serious long-term medical complications. Medical innovations, such as continuous glucose monitors and smart insulin pumps, are available to those who can afford them in high-income countries. But what about in less wealthy countries where funding and access to care are much more limited? In sub-Saharan Africa, although diabetes screening is now more common, treatment coverage is only 5 to 10%. Although the barriers and challenges for insulin-dependent patients are massive, solutions do exist. In Karno, Central African Republic, the care model that we implemented involves the patient as an active participant and is done at home. This is a major step forward that is radically changing the lives of patients who live far from healthcare facilities. This model includes self-monitoring of blood sugar levels. It requires access to fingerstick glucometers or continuous glucose monitoring patches, which are currently being piloted in MSF projects in Lebanon. Self-injecting insulin, which normally requires refrigeration to keep the insulin cool, often in areas with little or no electricity. A simple yet life-saving solution has been to use clay pots, which keep insulin at the required temperature. Around 40 years ago, insulin pens were developed, and these are preferred by most patients. They are easier to use, particularly in crisis or emergency situations, less stigmatizing, and less painful. However, in low-resource settings, these are rarely available, and patients are still given vials of human insulin with syringes and are expected to precisely drop the correct dose. Drawing up the wrong amount can be deadly. Insulin pens, like glucose monitoring devices and test strips, remain very expensive compared to vials. On top of that, there are several types of pens, either based on human insulin or insulin analogs. In 2024, Novo Nordisk, the main manufacturer of human insulin pens, announced that they were discontinuing production of this life-saving medication to prioritize a highly profitable drug intended for the treatment of type 2 diabetes and weight loss for people struggling with obesity. This will leave the more cumbersome vials and syringes, or the more expensive insulin analog pens, as the only treatment option for people with diabetes. When insulin was first discovered over 100 years ago, the scientists sold the patent for $1. Today, the majority of insulin manufacturing and sale is controlled by 3 pharmaceutical companies: Novo Nordisk, Sanofi, and Eli Lilly. The future of healthcare for people living with diabetes in places where the disease is most deadly is in the hands of a handful of private companies whose primary concern is their own profits. What are we asking for? A drastic reduction in the prices of pens and monitoring devices. The financial interests of pharmaceutical companies remain the main economic barrier to access to treatment in low and middle-income countries. We need sustainable financing solutions for non-communicable diseases. Revolutionizing diabetes care in resource-limiting countries is possible, provided that the current economic barriers are overcome.